Good morning. Thank you. Somebody said it back. That's awful nice. Thank you for joining us this morning for the Rocky Mountain MS Center's Fall Education Summit. It's really nice to see so many familiar faces. My name is Gina Berg, and I'm the CEO at Rocky Mountain MS Center. On behalf of our directors, our physicians, our volunteers, and staff, I'd like to welcome you today. We're pleased to have you here with us this morning on the University of Colorado's Anschutz Medical Campus, home to our team of neurologists, clinical, and research staff. This is the first time we've held an education summit on the hospital campus, and we're very happy to be here in surroundings that are so familiar to many of you. Hopefully it was fairly easy for everyone to get in today. What I'd like to be sure that you all do is give us feedback when you leave. So be sure to check in your folders and shoot us emails so that we know how that's working for you as we try something new. I'd like to take a moment to welcome a new group of guests. We have many folks who've joined us online. This is the first time we've live streamed an education summit, and we're glad to be able to bring today's event to so many people via the internet. We've had hundreds of people register to watch on the live stream from California to New York. I'm happy to report we have 23 states at last count, and hopefully many more will join as we're just getting started. So thanks to everyone who's here with us live and live streaming. Our Education Summit is a way that we can bring you the latest news on research and treatments for MS. And our Fall Education Summit is particularly important as the timing is right after the largest annual international conference of MS specialists. So it gives our doctors a chance to come back and share with you what they've gathered from that. We hope today's presentation will empower you with knowledge, insights, and strategies to help manage this very complicated disease that affects so many of our lives. I do hope you've had some time this morning and that you will have some time later in between presentations to visit our folks that are in the lobby area outside of the ballroom. The Education Summit is made possible in part by education grants from Biogen, Genzyme, Novartis, and Genentech. It's also made possible in part by our exhibitors, AbbVie, Acorda, Genentech, Genzyme, EMD Serono, Novartis, and Teva, and I'd like to give all of them a round of applause. Again, thank you for being with us. I look forward to visiting with many of you during the breaks. And now I'd like to introduce Carrie Chahovic, who is our Director of Programs at the MS Center. One of Carrie's many roles, but primary roles, is to serve as the liaison between the MS Center's nonprofit and hospital staffs. Excuse me. This morning, she'll also serve as our MC. Carrie?
Thank you, Gina, and good morning, everyone. It's so nice to be here with you all today. I want to welcome you all again to the University of Colorado Anschutz Medical Campus. As Gina said, it's so exciting to host our Education Summit here for the first time, since this campus is just such an important part of what we do here at the MS Center. Of course, the clinic staff sees patients just a couple buildings down there, but there's so much more to it than that. This is a teaching hospital, and our neurologists are also professors in the CU School of Medicine. They're helping to train the next generation of MS specialists. Our research team works tirelessly to better understand MS, and MS research now makes up the single largest area of research in the neurology department here on this campus. Later this morning, you'll hear from a panel of experts about strategies for living well with MS. We'll begin today with presentations from the co-directors of the Rocky Mountain MS Center at University of Colorado, Dr. Tim Vollmer and Dr. John Corboy. We'll then have a question and answer period, followed by a short break. And after that, we'll convene for the panel discussion I mentioned before. Just a few things in terms of, as we kick off, housekeeping-wise, please do silence or power down your mobile devices if you would. Restrooms are located just outside the conference hall and to your right, so if you head out the rear doors behind you, that's how to access those. There are also, if you need them, additional restrooms on the first floor, so you can take the elevator down. Question and answer, I mentioned that part of the program before. That's a key part where you have the chance to ask any questions that you have on your mind from the neurologist. So be sure as you're hearing the presentations this morning, jot down any questions that you have, and we'll have volunteers who are standing in the back of the room, raise your hands, circulating throughout the presentation period to pick up those questions from you all. So stay tuned for that. Then I'd also like to call your attention to an important part of your packet that you received on your tables there this morning, and it's the evaluation form. And that is a really important piece for us. We really rely on your feedback on these events to help ensure they're the best possible and most meaningful events for you each time. So please, you can leave your finished evaluation in the large blue box that's on the registration table when you leave. If you have any questions or would like to learn more about the work that the MS Center does, most of the staff members are wearing name tags, so we're easily identifiable and would love to talk with you more about our work. And we're just so happy to be with you here today. With that, I'd like to introduce our first presenter, Dr. Tim Vollmer. Dr. Vollmer is the medical director for the Rocky Mountain MS Center and co-director of the Rocky Mountain MS Center at University of Colorado. Thank you so much.
Thank you. Thank you. I'd also like to add my welcome to all of you to come to the campus here. It's a beautiful campus and it's an amazing place to work. So let me see. I'm going to be talking about maximizing lifelong brain health. Can you all hear me? Okay. So my purpose in talking about this particular concept is that it relates primarily to the anti-inflammatory drugs that we have. There are now 14 FDA-approved therapies to try to inhibit inflammation in the brain, which is the major driver of the problems that we have with MS. But this concept of maximizing lifelong brain health is actually controversial in the field. And so one of the reasons that I'm going to be going into some detail about the scientific background for this is to hopefully empower you so that you can help us advocate for being able to get access to some of the newer medications that are more effective and in some cases actually safer than our older therapies are. So the traditional way around the world to treat MS is what's called escalation therapy. And that means in most countries in the world, physicians start with the older drugs, the interferons and glutarimer acetates, and then wait for patients to, quote, fail on those before they actually move to the newer drugs. The concepts behind that are not very strong. What we're going to argue is that instead of that approach, what we'd like to do is to identify the optimal therapy for the individual patient based on trying to maximize the effectiveness of the therapy and minimizing the risk for that particular patient. So there is no single drug that's actually right for everybody. It actually requires some assessment of the drugs on an individual basis to select them. But I'd like to give you the scientific background for this concept. So first, just a couple things about the disease. MS actually is a leading cause of neurological disability in young adults in the United States. And it's also a fairly common disease around the world. The number 2.5 million has actually been upgraded to about 3.2 million estimated people in the world that have this disease. It's the second most expensive disease category in the United States behind congestive heart failure. And that's both because of disability and because of the drugs that we use. We do have a lot of evidence that what we call DMTs, or disease-modifying therapies, which are the anti-inflammatory therapies, actually do inhibit progression of the disease, decrease relapse rates, and can improve outcomes. And what I'm also going to try to suggest to you is that they actually can, if they're used correctly, in many patients, they can actually help them recover function and improve in terms of symptoms. So this terminology of relapsing, remitting, secondary progressive, and primary progressive MS is used universally around the world. But the terminology that we use, unfortunately, doesn't really identify the rational basis for the treatment of MS, in my opinion. And that is because the difference between these diseases, or these forms of the disease, doesn't appear to be based on the different biology of the disease, but rather based on the brain's capacity to mask what's going on in MS. So, this is very sensitive. So this is just looking at the costs that are associated with this disease. And the major point here is that if you look at the bulk of the costs here, they actually are related to disability. So one of the things that we're trying to argue in the world is that if we used the disease-modifying therapies, which are this cost up here, more effectively, we could then minimize these costs over here. And the goal is to use these therapies in a highly effective way as early in the disease course as we possibly can. And that's the controversy. Okay, so the major concept here for maximizing lifelong brain health has to do with the concept of neurological reserve, or brain reserve. And brain reserve refers to the ability of the brain to compensate for injury. This is not unique to MS. This actually is true in life in general. One of the realities for us as human beings is that our brains reach maximum size around age 30, and then for all of us, they begin to decline in size. But the brain can compensate for that loss of neurons by this reserve capacity, and it can do that by shifting function around. I'll show you some more information about that. There's another term in the field that we use called cognitive reserve. This actually comes primarily out of the Alzheimer's world, but it applies to MS as well. And cognitive reserve refers to the brain reserve capacity that's actually something that you can impact. You can actually increase your brain's ability to compensate for aging and for different diseases like MS, diabetes, hypertension, by actually living an active, healthy lifestyle. And so that provides, I'm going to show you some data for this, but that actually is an argument for a comprehensive approach to MS. So the key to here is that in order to maximize brain health and cognitive reserve, we need to help people actually develop active, healthy lifestyles. And so it is true that if you can adopt a healthy diet and prevent diabetes and hypertension, you can decrease the disability that actually occurs in MS. Likewise, if you actually develop an active exercise program, and this can actually be quite dramatic, you can also build reserve capacity, and that exercise also can allow you to recover function. And the reason for that is that when you are physically active and intellectually active, you're firing your neurons. And when you're firing your neurons, they make new branches, new connections. And if you happen to activate those new connections, then you increase the size of your neural network. It's like the internet. The more nodes you have, the more ways you can get around blocks, and the more effective the system can be. One of the keys to thinking about brain reserve is that it is actually related to brain volume, at least in part. And so the clinical measure that we use to assess this capacity is actually brain volume, and that's what we do when we do MRIs here is three-dimensional volumetrics. Okay, so this is the first data that I'd like to go over. The data I'm going to present to you is published in the medical literature, but it is actually not widely understood by many treating neurologists. And it's because these articles get published in hundreds of different journals, and it's hard for a lot of practicing neurologists to keep up with the literature in this detail. And the concepts we're going to be talking about are not actually summarized yet in the medical literature. But this is a paper from our colleagues in New Jersey who looked at the size of the brain and the ability of patients to perform on certain cognitive tests. And the point here is that people with larger brains perform somewhat better on these cognitive tests. This would also be true for motor function, balance, coordination, and other aspects of the function as well. And then they show here that if you start out with a larger brain, even if MS is active and you get more scarring in the brain, these T2 lesions, your brain can compensate for that and you can maintain your cognitive function. But if you actually have a smaller brain, then that increase in MS lesions in your brain actually results in a fall off in cognitive function. This is the evidence that living an active, healthy lifestyle is important. So here what they're doing is they're controlling for the size of the brain, and they're looking at statistically at the correlation between cognitive function and early life leisure activities. And what they mean by that is were you physically active, were you exercising, dancing, reading, learning new languages, all those things. And what you can see here is that patients that had more early life leisure activities actually did better on the cognitive testing. And again, that living an active life and actually currently also buffers for the effect of increasing MS plaques in the brain. So these are patients that are more active, they actually maintain cognitive function. These are patients that were less active and they have more of a loss of function. So this is the scientific basis for the comprehensive approach to the management of MS. So in order to really maximize lifelong brain health, there's several things that we need to do. First is we need to understand the concept and understand that it's not just for MS, it's also for normal aging. What we're trying to do is to save brain so patients, when they get to be 60, 70, 80 years old, can function normally and do the things that they want to do there. To accomplish this, we have to diagnose MS as early as possible. We have to help patients adopt a healthy lifestyle. And we also have to use the disease-modifying therapies, these anti-inflammatory therapies, as effectively as we possibly can, as early in the disease as we possibly can. So the first thing I'd like to go over is that the frequency of relapses and the frequency of new lesions forming on the MRI are actually related to age. Age is the most powerful predictor of whether somebody's going to have active MS. This is looking at relapses, So this is stratified by years since onset of MS, and this is by age. And what you can see is that young adults in 20 to 30 years of age have more relapses and actually more MRI lesions occurring. And then as they age, the number begins to drop off. And so it is possible, we believe, that if we can treat patients early in the disease course effectively, that they may not if we treat them effectively early, then we may be able to get to a point where the disease itself shuts off by its own biology, and then we can take patients off some of these disease-modifying therapies. And Dr. Corboy actually has a major grant to test that hypothesis. Okay. The second point I'd like to make is that most of the MRI lesions that are occurring are clinically silent. So MS is like hardening of the arteries. You don't really know what's going on until you reach a critical point. So this is some data from 7 patients that were followed over a year where they were getting MRIs on a monthly basis. And these dark green box here are relapses. And so you can see over the course of this 1 year in 7 patients, there were 5 relapses. If you look at these other numbers, these are the number of new MRI lesions that were occurring on the MRIs over the course of that year. And so there are 50 new MRI lesions that occurred in the population, but only 5 relapses. So 90% of new lesion formation in MS is actually clinically silent. And it's very hard for physicians to actually know that this is going on because the way that we do MRIs in the clinical environment, which is once a year, misses most of these new lesions that are occurring. And so the ability of physicians to actually know whether your MS is active by looking at MRIs is actually much more limited than many physicians actually believe. This is looking at the correlation between having new active lesions and rate of brain volume loss. And this is a technical slide, and I don't want you to worry too much about the details here, but the point is that patients that have very few lesions have very little brain volume loss, and patients that have a lot of lesions have a lot of brain volume loss. And these numbers up here, this R value of 0.75, what that means is that 75% of the factors that go into determine whether your brain is going to shrink is actually determined by the number of MRI lesions that you have. This is a critical point because many physicians think that the MRI doesn't correlate very well with disability. And the reason that they think that way is because of that brain reserve function that I was telling you about, where the brain is actually able to compensate for these new lesions, where you don't know that it's going on and the physician doesn't know what's going on until you reach a critical point. And that's when the brain volume now is up to a point where it can no longer compensate for this subclinical disease activity. Okay. This is just looking at the rate of brain volume loss as a function of different forms of the disease. And the point is, they're not really different. And the reason that this is important is because many physicians believe that brain volume loss is actually characteristic primarily of the progressive forms of the disease and not so much of the relapsing or the clinically isolated syndrome groups. But the reality is that if we correct for age-related changes, the rate of brain volume loss is actually greatest at the beginning of MS, at the very first onset of symptoms, and it actually declines over time as the inflammatory phase of the disease begins to wind down. The rate of brain volume change is actually the most powerful predictor of future disability years down the road. So this is one study that looked at that. This was done at the Cleveland Clinic. And it's just took patients that were in a study and divided them into 4 groups based on how much brain volume loss they had over the first 2 years of the study. They then followed them out to year 8, so 8 years of total follow-up, and they asked how likely were they to progress to a point where they needed to use a cane. And what you can see is that the patients that had the least brain volume change in this group over here, that was only about 14%. But the patients that had the greatest rate of brain volume change actually had almost a 55% chance of reaching that point. That's 4 times higher than this group over here. So that's a fairly powerful predictive value that we can use. And as a result, in our program here, when patients get MRIs within our system, we actually do 3-dimensional volumetrics as a primary goal for that MRI. And we're learning how best to use that in terms of deciding what therapies patients should be on. The brain reserve, as I've said, is the ability of the brain to buffer for disease activity. And the way that it does this is, as I mentioned, that the brain can rewire itself. It also can remyelinate. And there is some evidence that you actually may be able to make some new neurons in certain areas of the brain. Sorry. So this is what's called a functional MRI study. So we're just doing an MRI like many of you have had, but instead of looking at the typical markers that we use, we're looking at the amount of oxygen that's actually in the blood as it comes out of the brain. And that can be turned into a colored scheme on the brain and superimposed. So these, I'm sorry, this is hard to use. So this is a composite of many different patients that were studied. These are patients who had their very first MS attacks. It's called clinically isolated syndrome. And what they're doing is in the MRI, they're tapping a rhythm with their dominant hand. And then the MRIs are telling us what parts of the brain are being activated by that tapping activity. And what you can see here compared to healthy controls, MS patients are actually using more of their cortex and more supplementary cortex to do this task. So all these patients actually had normal function in their dominant hand. And they didn't actually have any symptoms in those extremities. And yet this is a manifestation of that subclinical disease activity. And this is evidence that the brain actually is rewiring itself in order to compensate for that subclinical activity. So this is a powerful bit of biology. And it's not just relevant to physical activity, it's also relevant to future therapies that are reparative. So for example, if one area that's not really being investigated right now is using different drugs to actually help neurons make these new branches and make these new connections so that if you're exercising or something, you can capture more of them. And that's actually theoretically possible. We have molecules that are available that do induce neurons to make more neurite sprouts and make more connections. So to summarize all of that, basically, I'm saying that relapses are more frequent in the early age. They decline over time. The number of new MRI lesions are also greatest at the early age, and they also decline over time. And these lines here are just indicating that if you're going to use an anti-inflammatory therapy, where you want to use it is up here, because this is where most of the inflammation is occurring. And if we can use it effectively up here, then we can prevent these downstream effects. The other thing I'm trying to point out here is that if we don't use it up here and preserve brain, then when we get out here, we may not be able to stop progression even if we shut off the inflammation. And that is because if we use up neurological reserve, we unmask the effect of aging on the brain. So that means that some of the worsening that we see in patients out here is actually just due to normal aging changes that are unmasked because we used up the brain reserve back here. So the disease-modifying therapies that we have are not all created equal. And this is just a chart comparing them on certain outcomes. So the first area here is their ability to reduce the number of attacks that somebody has. The second one is what's called a sustained disability progression. So this is a term we use in the field to identify the percent of patients that change in terms of disability, and that change lasts for more than 3 months. And in that case, then we consider that as clinically meaningful. We're looking here at MRI disease activity and here at brain atrophy. And if you compare these different medications, you can see that many of the newer drugs, the ones that have come out since 2005, have actually substantially more efficacy here than the interferons and glutaminyl acetates that have been out for almost 20 years now. That is also reflected in their ability to prevent progression of disability. So the newer drugs are significantly more effective, and this has been proven in head-to-head trials. Also, in terms of MRI disease activity, we see the same effects. They do basically correlate in a way, and also in terms of its effect on reducing brain volume loss. So for me, this is pretty straightforward. But again, most of the world still will use these therapies for the first several years and wait for patients to actually have increased disability or more relapses before they consider using these therapies up here. And the reason is that it's perceived that these drugs are cheaper than these drugs, and it's actually not true, particularly not in the United States. All these drugs are about the same cost. The second reason that they tend to do that is because they perceive that these drugs are actually safer than up here, and that's actually also not true if you do careful patient selection. So as I said, there's not one therapy I can say is right for everybody. So for example, rituximab and ocrelizumab, which is a new drug that should be out early next year, cannot be used in people who carry hepatitis B or C virus. Similarly, patients on fingolimod or Gilenya, if they have hypertension, cardiovascular disease, or significant pulmonary disease, this drug can worsen those problems, and so we would not use the drug in those patients. So the point is that if by looking at your general health and understanding your personal characteristics, we can actually select the drugs that actually have very good safety for you. And actually, in some cases, actually better than what we see with the interferons. One example here that's most widely understood is Tysabri, or natalizumab. So this is a once-a-month IV infusion we've had out since 2006. And the major problem with it is that quite a few people in the world have actually developed a very serious disease called PML, which is a viral infection in the brain that causes severe disability. But we have a blood test, and we can actually identify who carries that virus and who doesn't. And if we use that blood test and identify people who are positive and not put them on Tysabri, then we avoid that risk. If patients are JC negative, or the negative for the virus that causes PML, and we continue to monitor the blood test every 6 months, this drug is actually one of the safest drugs that we have. So it is possible in the world, I think, to use these drugs much more effectively than we have in the past. And if we use them in very early phase disease, we have a very good chance of actually putting people into clinical remission. And we see that in our clinic all the time, that patients that when we're using these more effective therapies on the top part up here, that many patients actually stop having relapses, their MRIs are stable, and they actually improve in function. And we have patients out now 8 years. In some cases, when we diagnose them early and treat them early, they tell us they don't feel like they have MS anymore. And so this is a very new opportunity that we have in the field, and it's something that if we can help the rest of the world understand this, we can fundamentally change the course of MS for in one generation, basically. So in summary, we believe that you should use these therapies in anybody who we think is still in the inflammatory phase. For me, that's pretty much anybody below the age of 55, because statistically, you're more likely to still be in the active phase than not be in the active phase. But over the age of 55, we're not quite sure yet. And Dr. Corboy's study hopefully will answer that question. The question of which therapy to use for a patient is really one that has to be individualized. So we want to adopt the most effective therapy that actually prevents relapses and new lesion formation, but while assessing the safety profile for that particular patient with the drug. And this is something that actually is quite doable today. Our goal in relapsing-remitting MS is actually to achieve what we call no evidence of disease activity, which means no relapses, no progression of disability, and no new MRI lesions. And we also want to normalize brain atrophy rates. Now, we're not quite sure yet that we're able to do that, but our preliminary evidence suggests that we can. And we also, in our center, our goal in relapsing MS is actually to improve symptoms and hopefully minimize disability. In progressive forms, our primary goal is to prevent further progression of disease. But I think in the future, Dr. Corboy will probably talk about this, there are evolving therapies that may help us actually induce repair in the nervous system and help progressive patients also improve in terms of function. So with that, I'd like to, again, thank you all for coming. And if there's anything we can answer for you, any questions, please let us know. Thank you.
Thank you very much, Dr. Vollmer. Appreciate that. For those of you in the Denver metro area, there will be a chance to have a even more interactive presentation time with Dr. Vollmer. We have a Conversations on MS series, and Dr. Vollmer will be participating in early December. So stay tuned for more information on mscenter.org for the time and date there. Also, I want to do a quick shout out to the folks participating in the live stream presentation. I mentioned the evaluation for our in-person participants, but there will also be an evaluation for those of you who are tuning in from your homes today. So stay tuned for that. With that, I would like to introduce the co-director of Rocky Mountain MS Center at University of Colorado, Dr. John Corboy. Thank you.
Thanks, Gary. Thanks for coming, everybody. I'm going to hit on a lot of similar topics as Dr. Vollmer did, but I'm going to add a few other things as well. And so you guys are the guinea pigs. It's the first time I ever made this talk up, so we'll see how it works out. And I'm sorry I have the wrong date on there. That's the date from the last one. There's my disclosures. As Dr. Vollmer suggested, or really outright stated, the goal of MS therapy from our point of view is lifelong brain health. I would also add spine health. There's a lot of disability that accrues, especially related to walking, with regard to the spine. So the spine is all part of the same concept. I think all the things that we say hold for the brain as well as for the spine. And so this is just a reminder for me to talk about what MS is. And it's really a complex disorder of the brain, the spine, the optic nerve, and is caused by an interplay of genes and environmental factors, and composed of both degeneration that we saw with that atrophy that occurs very early in the course of the illness and persists over time, but also composed of inflammatory disease, where in theory the immune system attacks the nervous system, and we can see this inside the lesions at either autopsy or biopsy, where immune-based cells, lymphocytes, white blood cells, and other immune mediators are attacking the nerves. And we know that degeneration occurs very consistently throughout the lifetime of a patient, but as Dr. Vollmer noted, the inflammatory component of the condition tends to be relatively early on in the course of the illness. And that's important because the presently available therapies that we have are all anti-inflammatories of one form or another. And so this is the natural progression of MS. This is an old slide, but I think it still holds up. There's a subclinical component that occurs early. We know that now because people might get an MRI scan because they have a migraine, or were involved in some sort of a head trauma with a car accident, and yet they get an MRI scan of the brain. It looks just like MS. We call that radiologic isolated syndrome. Pre-symptomatic or subclinical activity occurs before there's any clinical symptoms. But then there's, let's see, do I have a, here I can do it here. No, I can't. Oops, sorry, this one. So there we go. Oh, there we go. Okay, good. There we go. Sorry. But then we have the monosymptomatic event, or a clinically isolated syndrome. And then when people go into a relapsing phase, and then as people age, many people, not all, go into a slow progressive phase called secondary progressive MS. And of course, some people never have relapses, and we refer to that as progressive onset or primary progressive MS. But there's ultimately, for most people, this early clinical event, this clinically isolated syndrome. Over time, there are more of these, and then over time, there are less of these. But what happens overall, though, if we look at the level of disability, because of our cognitive reserve and our brain reserve early on, you're able to remyelinate, you're able to fix your nervous system. As people age, that becomes less and less possible, and there's more development of disability. And with regard to accumulated MRI lesion burden, that is the total number of white dots, that increases over time as well. Unfortunately, although the dots may shrink, especially with therapies, they don't go away typically, and they accumulate over time. Ultimately, the number of new lesions, the enhancing lesions, as on the purple here, those actually diminish with age, as do the relapses. But also, the cognitive function diminishes with age for many people. And then the biggest point, of course, is brain volume. Brain volume or atrophy is extremely important. It is a major predictor. It's the #1 MRI predictor of how people are going to do over time. And that's why we're so focused on trying to maintain brain volume, especially early in the course of the illness. So again, this is another little reminder for me that as we push further and further to try and make a diagnosis earlier and earlier, we can run into the problem of misdiagnosis. And we still have a lot of patients with some vague symptoms and maybe a normal neurologic exam, but they have little white dots on their brain scan, and we need better biomarkers. This is from a colleague of ours in Vermont, Dr. Solomon, and he looked at patients with little white dots on their brain scan who had migraine and little white dots on their brain scan who had MS, and was able to identify that in the MS brain at the top compared to the MS brain at the bottom using a sequence called a 3T flare star. So it's a 3 Tesla, the bigger magnet. The usual magnet is about 1.5 Tesla. And it's a flare sequence, which is the most common sequence we use to look at the little white dots on the brain scan. But it's a star sequence. And what that allows you to do is it allows you to see that the lesions themselves in MS are wrapped right around a vein. This is looking at the vein on end, wrapped right around the vein, whereas in migraine, that's not the case. And so as we talk about all these things and trying to diagnose people earlier and earlier and earlier, to treat them earlier and earlier, we have to make sure that we get the correct diagnosis. And we need techniques like this, or we need other biomarkers and other things like that to make sure that we're doing the right thing at the outset. And we know that even before people have obvious symptoms, an optic neuritis, a spinal cord syndrome, a lot of different things are happening. I discussed already, people can have a radiologic isolated syndrome, lesions on their scan that look just like MS, even though they've never had clinical symptoms. Well, this is a study that was just published very recently that looked at people in the so-called nurses studies, and there's 2 of them, these very large databases where women have been filling out, and it's all women, have been filling out questionnaires for literally the last 40 years or so in 2 different studies. And then you can correlate what's been happening with them over time because they've been followed all that long period of time. And in that time frame, several hundred women have been diagnosed with MS. And you can go back and mine this database and say, well, what was happening to them at the very beginning? And the thing that is notable here is that in this study, you can see that there's the year from first symptoms and the year from diagnosis. And what you can see is even before diagnosis, this has to do with exercise activity. And even before someone is diagnosed, and even before they've first had overt symptoms, already people have changed their exercise and activity levels. There's something happening even before they have symptoms that is resulting in a change in their behavior. And in the study, it shows that even people that continue to exercise, unfortunately, that did not necessarily change their outcome. But there's something happening even before they have clinical symptoms. And so, as I mentioned, there's this radiologic isolated syndrome phenomenon, and we can see people who have lesions on their scans before they're diagnosed, before they even first have symptoms. And so what happens to these people over time? And this is from Darren Akuta. This is now a large international trial. This is a couple of years ago when they were up to about 450 patients. Now they have quite a few more. And what happens to these patients over time? Do they act like patients who've had a first clinical syndrome, or do they act differently? What happens to them? And if you follow them long enough and look to see when they have a clinical event, indeed, they have clinical events at about that rate. And by 5 years, about a third of them have had a clinical event that's typical for MS. And if you look at patients, for example, in the optic neuritis treatment trial, it's a similar number. And even in the optic neuritis treatment trial, that is someone who had an optic neuritis as a first event. And if they had 3 lesions or more on their brain scan, that number is about 50%. So even people without clinical symptoms are acting pretty much similarly to patients who've had clinical events already. And so can we figure that even a little better? Is that just everybody's like that, or are there differences? And in a further study, the Akuta team looked at patients and broke them down by women versus men, if they had spinal cord lesions or not, and also by age. And if you look, there's all sorts of ways that you can pull this apart. So up at the top here, if you had spinal cord involvement, much more likely to have a clinical event compared to not. If you were over or under the age of 37 years, you were more or less likely to go on to a clinical event, those being less than 37 years having a higher risk. Men versus women, men were more likely to have a clinical event. But importantly, if you were a man under the age of 37 and had spinal cord involvement, you can see within just a year or 2, your risk of having a clinical event is almost 90%. So you can look at patients who've had these little white dots on their brain scan that look like MS, and you can really pull apart people who are at risk of developing clinical symptoms very early. And to get back to brain atrophy for a moment, there are a variety of different studies looking at brain atrophy in patients with radiologic isolated syndrome before they've ever had clinical events occur. And this is just one that was published a couple of years ago, showing that individuals with radiologic isolated syndrome or clinically isolated syndrome compared to age-matched controls, looking at total brain volume, it's already decreased in comparison to patients who do not have these syndromes. In specific, it looks like it's involving the cortical volume, and that's important because for many years we thought that this was all a white matter problem. The white matter is the axons with the myelin wrapping around connecting one nerve to another. The reality is that there's a significant amount of disease activity going on in the outer mantle of the brain, the cortex, where the nerve cells themselves live. And although it's not as easily seen on brain MRI scans, there's clearly activity that is going on. In fact, if you look at the white matter is actually not really different. So early on, cortical volume is probably lost preferentially compared to white matter volume, and that is not a small issue. You can also look at this looking at metabolic aspects of the nerves. And this is looking at N-acetyl aspartate, which is a neuronal marker. And if that is down in an area that you're looking at in the brain, this is a different way you do the MRI scan to do spectroscopy, then that suggests that the neurons themselves are not functioning very well. And this is in very early patients and with radiologic isolated syndrome. Again, never had any clinical symptoms whatsoever. And if you look in the central brain at normal appearing white matter, if you look at the lesions themselves that are in and around the ventricles and deep in the brain, as many of you know, or just look at interhemispheric, comparing the sides, that in all cases, the patients with radiologic isolated syndrome compared to healthy controls have less neuronal function based on this metabolic pattern. All of these things are occurring before anyone's had any symptoms at all. What we'd really like to have as well is a marker of very early disease activity that's not just on the MRI scan, but also would be a factor we can measure in blood. Spinal fluid is okay. Obviously, a lot of people don't want to get recurrent spinal taps over time or even one. And so for many years, people have been looking at markers of neuronal damage in spinal fluid and now more importantly in blood. And this is one that has perhaps the best chance of being a marker for disease activity. And this is looking again at very early patients. They had clinically isolated syndrome. And some of these patients converted to clinically definite MS, that is, had a clinical event. And some just stayed with clinically isolated syndrome, that is, did not have a second event. And what you can see is that those that converted over to having a clinically definite MS, having a second clinical attack, had in their blood an elevated amount of this neurofilament light, which is a marker of, again, neurons. And what this represents is as the damage is going on with the neurons, there's leakage of this marker, and you can measure it in the blood. You can also measure it in the spinal fluid, which is perhaps better, but using that over time is more challenging. More sensitive techniques now allow us to measure this in the blood and tell us that this is a person that has obvious ongoing activity. So the purpose and the importance of this is that this is now a marker that we may have in the blood that can tell us extremely early that there's damage that is ongoing and can help us define people not only at risk of having another attack, but also that someone you're going to want to treat very aggressively. And this is just another study that shows the same point that was made multiple times by Dr. Vollmer of the importance of brain volume. If you look at the individuals in this study, this is published just a couple weeks ago, that have the highest leakage of this marker, this neurofilament light marker. So on this axis, more leakage. And if you look at people at both 1 year and at 5 years, what happens to them over time if they had a high amount of leakage of this marker, the neurofilament light, what happens to their brain volume and the loss of brain volume? So going down is loss of brain volume. And you can see there's a pretty good correlation, especially at 5 years, a very good correlation. Those who had the most neurofilament light leakage at the outset, when they first had a clinical attack, 5 years later, they are showing the greatest amount of brain volume loss. So this is a marker that we may well be able to use to help define, especially those at significant risk of having a significant event, loss of brain volume over time, even from their very first attack. So this is not yet commercially available. The hope is that this will be commercially available soon. And several of these slides just get to the same points that I've made. If you look at clinically isolated syndrome and relapsing MS, brain volume loss is already significant compared to healthy controls. And this is cortical atrophy again. This is the same slide that Dr. Vollmer showed, showing that over a lifetime, the brain volume loss is early, it persists over a lifetime. And we're trying to interrupt that. Everybody in this room over the age of 35 or so is already losing brain volume because that's normal. However, the brain volume loss is about 0.15 to 0.2% per year, and it's 2 to 3 to 4 times more in people with MS. So the goal of many of these therapies should be, and is now being watched very closely, is whether or not we can have individuals who go on therapy X, Y, or Z and normalize their brain volume loss to the same as everybody who does not have MS. And we have 3 different studies looking at that with glatiramer acetate, with natalizumab, and with fingolimod. And why does it matter? This is from Pierre Sermani a couple of years ago, showing very clearly the treatment effect on brain atrophy correlates with disability over time. And this is a compilation of multiple different studies, but it showed very clearly that the two major factors, both atrophy of the brain as well as the lesion volume, when you have the biggest effect on changing those with the various therapies, you have the biggest effect on disability. And ultimately, that's what we care about the most. So we talk a lot about brain volume, and the reason why is because of this. This is the same slide that Dr. Vollmer showed. He got his in color, though. I like his better. And, but buried in this argument by Dr. Tremlett from Vancouver is a quote that says, from the population perspective, the impact of any therapeutic agent targeting inflammatory processes, and all these medicines that we have, that's what they do, the greatest effect is early on, and it's because of this data and others. And we know that, so the relapses diminish over time. This is one of the other studies showing what happens if you look by age at enhancing, active gadolinium-enhancing lesions, peak in the 20 to 40 age range, significantly lower in patients who are in the 50s and 60s. So that's just the backdrop to say that there is a lot of activity that is going on very early in the course of the illness, even before people are clinically symptomatic. And then how does that drive what we do? And should it drive what we do? And we feel strongly it should drive what we do in terms of how we treat people. So what are the approaches to actually treating MS at this point in time? So it would be really nice if we could avoid getting it all together. And there are a number of studies that are looking at very early signs of multiple sclerosis. And we have a grant we'd like to get going, a proposal to look at individuals who are first-degree relatives of patients with MS, either children or siblings of people with MS, because their risk of developing MS is extremely high. And to try and look at that patient population, to try to see if they, for example, have this neurofilament light in their blood, other biomarkers, what is their vitamin D level, what is their exercise status, what is their ideal body weight and how close are they to it, and other things, to try to identify are there identifiable ways that we can intervene even before someone has symptoms to try to stop them from getting it. But right now, that's still out there, and we don't have that possibility. But we have many therapies which alter the immune system. We'll talk a little bit more about those. Those are the presently available disease-modifying therapies. But we might also want to protect nerves from degeneration, and I'm going to talk a little bit more about that later. We might want to enhance normal repair in the central nervous system, and there are now studies going on looking at repair. I'm not going to talk too much about those, but I'll at least allude to them. Or you might want to replace cells in the CNS. We talk a lot about stem cells. Stem cells might be available to try to alter the immune system or to replace cells in the central nervous system. Right now, the ones that are presently available are going to be doing this. What we'd like is the ones that could also do this. So there's really not much to talk about with regard to these right now, unfortunately, but that's one of the places I think that we need to go. So the MS treatments in 2016, we have a variety of things that you can do. Behavioral changes, just getting extra good sleep, make sure you have a vitamin D level that's good, not smoking, perhaps low salt intake, although the data is not great with that. Aggressively treat comorbidities, diabetes, high blood pressure, hip, knee, spine disease, and other things. Those things, if you have those, not only delay the diagnosis of MS, but also are associated with a worse prognosis in MS in the sense of the way people function. If you need to have your hip replaced and you're walking poorly because of that, and you also have MS, you're going to have a double header trying to interfere with your walking. Exercise, exercise, exercise. We could have a whole talk about that. Exercise has been shown to be extremely helpful in a variety of different contexts for MS, and we strongly promote that. Treating the acute attacks, as many of you know, with high-dose steroids or plasma exchange. Symptomatic therapies, which again by itself is a 2-hour discussion, but we'll talk a little bit more about now some of the disease-modifying therapies. I'm not going to go over all the older therapies that have been around for 20 years. I'm going to talk about somewhat what the new data is for some other ones and talk a little bit about progressive MS as well. And so this is just the catalog of what's been approved since 1993 in the United States, Europe, and elsewhere with the various different medications. which, and many of you are probably aware that in this year, daclizumab, Zimbrita, has been approved. It's an injection taken at home once a month and is available now, and I'll discuss that in a moment. Ocrelizumab, or Ocrevus, which is very similar to rituximab, should be approved between now and December 28th. And then there are a variety of other medications that are either similar, such as ofatumumab being the same family as ocrelizumab and rituximab, and there's another medicine that we are noting out in front with one of our studies that's also in this family of anti-CD20 molecules. There are other molecules like Gilenya or fingolimod, other sphingosine 1-phosphate agonists, and then a whole host of other medicines, some of which have been around for a while and have not yet been approved in the United States, that may get approval, and then repair strategy stem cells. And notably, many of you may know that the first generic became available last year in our market for generic glutaric acetate, referred to as Glatopa, and there may well be more generics coming as well. So what's sort of new in a big picture sense? In the big picture sense, a variety of things are new. Glutaric acetate, more convenience dosing has been available for the last couple of years, now only 3 times a week, sort of limiting the biggest argument against using Copaxone, which is the daily injection, which is quite bothersome for people. Interferon beta 1a, previously Avonex. In this version, it's Plegridy, which is a higher dose, but taken every 2 weeks, which again improves its convenience for its use. Daclizumab, as I noted, is approved, and I'll show you a little bit of the data in a second. There are a variety of different studies that have been shown in the last year or so, showing prolonged and sustained efficacy with a variety of different medicines that we use, and several of them are listed here. That's important, so that one of the biggest complaints for our studies is that, well, the studies are only for 2 years. Well, it's hard to do a placebo-controlled study for 20 years, but these studies have shown persistent, prolonged good benefits, and that's important. There's also data looking at improved risk. Natalizumab, Tysabri, is associated with PML, progressive multifocal leukoencephalopathy, and that's a substantial risk. There are now over 700 people that have developed this complication, which is fatal in almost 25%. That is a very significant problem. So starting about 2 to 3 years ago, about 10 groups around the United States asked the question, well, what if we, instead of using it every 4 weeks, use it every 6 to 8 weeks? That is extended dosing. Does that do anything to alter the risk of this medication? And does it maintain the same level of effectiveness? Because we know just from kinetic studies, the way this drug works, it's a monoclonal antibody that attaches to a molecule on a white blood cell and just hangs on. But over 8, 12, 14, 16 weeks, it'll just fall off and that white blood cell will be active again. So at 8 weeks, it should still be effectively functional. Maybe some of those molecules have fallen off. Maybe some of those white blood cells can help get rid of the virus, but at the same time, there'll be enough white blood cells available that are still hooked up that will remain effective against multiple sclerosis. And in fact, that's exactly what's been shown so far. The effectiveness in this about 2,000 person study, about 1,000 in each group, people taking regular dosing versus extended dosing, the effectiveness has been about the same. But so far, there have been 4 cases of the PML. All of those have occurred in the every 4-week group. None have occurred in the every 6 to 8 week group. So even in that context, we may be able to mitigate the risk. And many of our patients feel very strongly about staying on natalizumab because they've had such powerful benefit from it. In our experience with natalizumab, Tysabri being the only medication that people take where they really feel and function better on a routine basis, and taking that away, they feel less well, and they want to stay on the medication in spite of being JC virus positive. And this is by no means definitive, but this may be one way that you could stay on the medication. As I alluded to, the generic glutaric acetate, the first one has come out. There's probably going to be another one come out sometime soon. One company, Synthon, has a similar molecule where they compared it directly on the daily basis, the daily Copaxone versus daily their Synthon product, and it was equivalent. And then in addition, there's some variety of other studies, including studies looking at extended release or sustained release baclofen, which would be very important, especially for people that have a lot of spasms or jerking movements at night that wake them up, to be able to get them through the night and not have to wake up with those. This is the daclizumab. It's a daclizumab high-yield process is the HYP, and it was compared to Avonex in one of their studies. And if you just look up in the top here, the annualized relapse rate was substantially reduced. Here's the interferon beta-1a. Here's the daclizumab was reduced not quite by half. And if you also look at MRI outcome measures, also a substantial reduction in new or enlarging T2 lesions. This is very similar to all of the studies with all of the other medicines that are approved. This medicine has some challenges from a side effect point of view and does have a risk mitigation strategy as mandated by the FDA due to enlarged lymph nodes, some liver function problems, and skin issues. Many patients do tolerate it well. We were involved in one of the studies, and for patients that tolerate, this might well be an option. It does have the convenience of once per month, but the side effects will potentially significantly limit their usage. We've shown this now for the last year or so, but maybe not all of you have seen it. This is more important now because this is the data with ocrelizumab. Ocrelizumab will almost assuredly be approved right around Christmas. This is the two OPERA studies. That is the two studies in relapsing MS patients, 18 to 55, patients with active disease when they started. And it was a 2-year study directly comparing them. And if you look at the relapse rates, which was the primary endpoint in the patients with the interferon compared to the ones with the ocrelizumab, which is taken essentially 2 shots the way it was done, 2 IV infusions for the first dose, and then doses 2 through 4 were a single every 6-month infusion. A substantial reduction, almost half compared to an active comparator, not compared to a placebo, compared to an active comparator. So that's a substantial reduction, way more than the earlier older drugs showed compared to placebos, which was about a 30% reduction. This is the data pooled for OPERA-1 and OPERA-2. There were 2 of them. When you look again at this NITA, no evidence of disease activity. And if you look at it from 0 to 96 weeks, there's about a 75% improvement. Over almost half the patients have no relapse, no scan change, no change on their examination. If you relook at it a slightly different way and take out the first 6 months, because we know with the way this medication works and the way many of the medications that we use work, if there's going to be new disease activity, it's going to occur in the first 3 to 6 months. And so if you do what's called rebaselining, sort of starting the clock anew after the drugs had a chance to take effect, then what happens to this NITA? Well, if you look at what happens to NITA then, the NITA goes up dramatically even more. And compared to the interferon, almost a 200% improvement in the number of people that have no attack, no scan change, and no exam change when you look at them. This number, just sort of keep that in your head. Keep those 2 numbers in your head just for a moment. In addition, with ocrelizumab, a study was done with primary progressive MS or progressive onset MS, those individuals who've never had relapses before that have shown consistent slow worsening for at least 1 to 2 years going into the study. And it was compared to placebo, not to an active comparator, because there's no approved drug for primary progressive MS. And the primary outcome in this context was the number of patients who at 3 months had confirmed disability progression, CDP, that was less likely to change on your examination and show more signs of disability. And it was about a 24% reduction in individuals who had a change in their EDSS examination. When you also look to see how that was at 6 months of confirmed disability progression, it was actually the same. And then there were a variety of other outcomes which were also better compared to placebo. It's on the basis of this study primarily, which is extremely exciting, the first ever primary progressive MS trial to reach its primary endpoint of less disability, that the FDA should approve this drug on so-called fast-track status by the end of December. And we're hopeful that that will occur without any significant interruption. But in addition, reported at ECTRIMS in London a couple of weeks ago, was the largest study ever done in secondary progressive MS. Secondary progressive MS is the most common form of progressive MS. depending upon what study you look at, in natural history, anywhere from 40 to 60%, perhaps 70% of people with so-called relapsing MS, as they have less and less relapses over time, may have slow progression that mimics primary progressive MS. In fact, has about the same time of onset, age of onset, and in addition, also acts the same in terms of how people progress. And most disability occurs during this progressive phase. And so this is a study, it was over 1,600 patients, 2-to-1 enrollment, so 1,100 got treatment with the drug and 546 got placebo. Here's the criteria. This went up to age 60. They too had to be progressing in the 2 years before screening. And the main outcome was, again, 3-point confirmed disability progression as measured by the EDSS. And there were MRI scans along the way and all these other visits along the way as well. And here was the dosage that was taken orally. And so here's the main outcome, very similar to what we saw in the primary progressive MS trial, about a 21% risk reduction in the likelihood that you would have a change in your disability over the 2-year cycle. And actually, quite a few people went beyond the 2 years. It was actually about a 3.5-year study. Some patients were only in as little as 18 months, some as long as almost 4 years, however. And all the side effects and potential issues are noted here. Many of these are quite similar to fingolimod, Gilenya. This is in the same general family, and there are several other medications also being studied in the same general family. And this is the first large study like this that showed a benefit of this nature. Here are some of the other endpoints that were also noted. And in this study, they also did, it's not on the slide, but they did show us the breakdown based on younger versus older, men versus women, having active lesions or not active lesions on your scan. And just like many other studies, when you look at subgroup analysis with progressive MS trials, younger patients, those with active lesions on their scans, and those with recent relapses clearly did better than those who were older, no relapses, no active lesions on their scan. Again, supporting the concept that these anti-inflammatory medicines will work better in that context. So many people ask about stem cell transplants, and the stem cell transplants that are presently available really mostly come in the context of either simply taking stem cells from the arm or from bone marrow, taking out those samples, taking the stem cells, there's a certain marker where you can pull out those that have that, put those aside, and either just simply inject those back into the same person's arm, that is their own cells, or more commonly, to store those cells and then suppress the bone marrow substantially, do high-dose immunoablation therapy to ablate or get rid of the bone marrow, take the stem cells that you've stored, give them back to rescue the bone marrow. That is the most common context in which stem cells have been used in multiple sclerosis and a variety of other conditions as well. The idea is to reboot the immune system. So this should be thought of as an immune-based therapy, and it's not clear, is the high-dose immunoablation therapy the therapy? Is the stem cell rescue the therapy? Or is it really both? It's probably really both, but that's hard to pull that apart. But one way or another, this is not meant to replace damaged cells inside your nervous system. This is to reboot your immune system. And so a meta-analysis was done, again by Pia Sermani, that was published recently, and suggests that these autologous, that's your stem cells, transplant may be an effective approach for treatment of aggressive forms of MS. These are young patients, very active disease, multiple relapses within the last year, highly active MRI scans, failing multiple therapies. Those are the people that get into these studies because the reality is that this is a potentially quite dangerous and harmful approach. But for these patients, and these are uncontrolled studies, they're not compared to other things, they're open label, everybody knows what they're getting. There's mortality associated with these. These are 15 studies, over 700 patients. There's mortality associated with these. Progression rate at 2 years, about 17%, which is not bad. And if you compare on those previous slides, that's actually pretty good compared to some of those other medications for progressive MS. Here's the thing I wanted you to remember the NIDA for. After 2 years or after 5 years, the NIDA rates, no evidence of disease activity, is extremely high in comparison to most of the studies that we talk about. And notably, These are highly active patients. So for highly active patients, this may be a very effective approach. But again, especially there's one study, the BERT study, which was published, it's the largest one of these, published in JAMA last year. Dr. Burt is from Northwestern. He's an oncologist from Northwestern. He pretty clearly showed, again, this is effective for younger patients, not so much for older patients. In fact, not really at all for older patients. So let's just talk for a moment about determinants of therapy choice. There's really a lot of patient issues, doctor issues, and sadly, a lot of insurance issues here in the United States as well. But ultimately, as Dr. Vollmer noted, this will become a very individualized approach. Every patient is going to be different. Pregnancy may play a role. A variety of things may play a role that you have to try to make the best determination with the patient as to what is the right medication for them based on a whole host of factors. But in many respects, the two biggest factors that we come down to oftentimes are what are the benefits, the effectiveness of the therapies, and what are the risks of the therapies. And what we clearly don't want to do is we don't want to have those with low effectiveness but high risk. That's really not a very good combo. In the perfect world, we'd have very high effectiveness and very low risk. And so the question is, what do we really have? And this is sort of what we really have. We have, by effectiveness, maybe low, medium, and higher effectiveness. And then we also have, looking at risk, we have some that are going to be relatively higher risk and some that are going to be relatively lower risk. Glatiramer acetate really has very few risks associated with it other than the injection site issues. And as noted, patients with natalizumab, if they're JC virus negative, may be low risk compared to higher risk if they have the JC virus that's already been in their body. So what we'd like is stuff down here, and we strongly believe that the anti-CD20s and natalizumab, when they're JC virus negative, put you in this best category over here, and that's a lot of what drives our behavior. And so ultimately, this is the risk-appropriate approach, balancing risk of disease with risk of the therapy, as well as all the other issues, personalizes the approach, recognizes each patient provider has varying views, and recognizes all the spectrums, but emphasizes efficacy or effectiveness as the primary thing that drives our decision-making. And I'm running late, so I'm going to skip through this because we've sort of already seen a lot of this. But the logic would be treat early, treat aggressively, and this is why. To go to an EDSS of 3, this is from the Barcelona group, they could show that people that got treated before clinically definite MS, compared to after clinically definite MS, likelihood of going to an EDSS of 3, that's moderate disability in at least one subscore on the 7-point EDSS scale, substantially greater in people that waited. This is published about 4 weeks ago. This is from the Beta Seron 11-year follow-up study looking at people with clinically isolated syndrome, showing that the people got the placebo group compared to people that got started on Beta Seron from the outset, a 2-year delay. This is, again, clinically isolated syndrome, a single first attack, showing that there are still benefits to the people that started early in terms of the likelihood of having a second clinical event. It's delayed. The annualized relapse rate is lower in the early treatment in the purple. And then also you can see that there still is disability that accrues over time. And as good as this is, and this is nice they showed it, in this population using a medication that we feel is relatively less beneficial, 33% unemployed or working less than 11 years, and 33% with an EDSS of 3 or greater. That is significant disability. So even with this early treatment, there's still a significant number of people who go on using this less effective therapy from the outset. But again, using Beta Seron as an example, again, this is from the original pivotal trial in people with relapsing MS, showing 21 years later that mortality rates are lower in the people that got therapy 2 years earlier compared to 2 years later who are in the placebo group. 21 years later, they were able to ascertain 98% of the people in this trial, and there was lower mortality, and it was due to less MS-related deaths. I'm going to run over. So I want to talk about this because this is important. Progressive MS. Dr. Vollmer nicely laid out what the issues are related to that. In many respects, we view this as a power failure, and that's why the cognitive reserve is diminished over time. Power in the cells in your body comes from mitochondria, which are separate organelles inside your cells. The DNA that comes from this comes from mom only. It's not transmitted via sperm. But ultimately, you make ATP. ATP is the power plant for all the cells in the body pretty much, except for a few exceptions. And so this is the Krebs cycle of the respiratory chain. You create this because of this, and you get these ATPs spun off. I mention this because there's going to be a study coming up very shortly looking at biotin, a supplement in high dose that will help drive this. And biotin will interact here as well as here, pushing this cycle to make more ATP. Why do we care about ATP? Well, this is what happens with progressive MS pathologically. This is from Bruce Trapp from last year and Hans Lossmann. And if you look at ATP, these are the mitochondria in green here. There's a demyelinated axon. What happens is you increase, in order to push the nerve potential, you need to have more energy when you have damage to the axon. Over time, these mitochondria that make the power plants, make the ATP, these mitochondria get mutated and get damaged. And over time, there are more and more of these, and this nerve will fail. That's what happens, and we think that that's what leads to the dropout of nerve cells and atrophy over time. And the other way to look at it is here, you need more ATP in a damaged cell because normally, in order to make the potassium go out and the sodium go back into the cell, which is how you move electricity along the nerve, you need a limited amount of ATP. It's all linked to this cycle here. You need more ATP if you have a damaged axon. So you need more ATP, it fails over time, the cell dies. So can we do anything to give the cell back ATP? And the answer is potentially we can. So this is in a study of the French group, the company is called MedDay. This was published this year. This led to a larger study that we'll be doing shortly with MD 1003. Compared to placebo, about 1 out of 8 patients in this double-blind controlled trial, 154 patients total, about 1 out of 8 patients actually improved with regard to disability with progressive MS. And if you look at the patients who then went from placebo transferring over to the group to the treated group after 1 year, they also had improvements. And who were these people that improved? They were 54, they were not 25. Many patients with secondary progressive MS. Mean duration of disease, 15 years. Mean EDSS at starting, 5.8. That means almost using a cane. These were significantly impaired patients who showed improvement. And so on the basis of this, a large 450-person study is going to be done, probably starting to recruit in a couple of months in this regard, placebo-controlled trial. And this is just showing what happens to the EDSS. This is the treated group. This is the placebo group at 1 year. They flatten out with the loss of their, or the change in their EDSS. And this is a compilation of all these other studies with progressive MS and what happens in the placebo groups to the patients in those studies with increasing, worsening disability. So this is lipoic acid, another potential medication that might be used for progressive MS to maybe improve things. This is an antioxidant. And in a study done in the VA, very small numbers, 27 and 24, they were able to show a significant reduction in brain volume loss over a 2-year period of time. This is over 2 years. That's about 0.25 per year, 0.22 per year. That's almost what it is for people without MS compared to people who got placebo. So a larger study is planned for this as well. So I'm going to skip this because I've talked about this recently, and Dr. Vollmer alluded to it as well. We do have a study that is going to be starting shortly looking at potentially discontinuing disease-modifying therapies in people who are older who have been stable for a prolonged period of time. The logic being that the therapies probably have less benefit as people age as anti-inflammatory benefit. And so it'll be randomized, people 55 and older who've been stable with no scan change or relapse change for at least 5 years on whatever medication they're taking. Half will be randomized to stay on, half will be randomized to stay off. follow the patients for 2 years, and see if the patients who go off the medication do no worse, it's a so-called inferiority study, do no worse than those that stay on their therapy. And the hope is that we'll be able to at least answer this question whichever way so we can guide people better, because right now we have no data that these medicines do anything in people over the age of 55, and so this will at least get us some data in patients who are over the age of 55. So thanks very much for your coming and for spending your morning with us. It's a beautiful day. Get out there and do some exercise.
Wonderful information and presentation, Dr. Corboy. Thank you so much. Just a reminder, I know folks have been submitting questions throughout, so thank you for that. If you do have any remaining questions, be sure to give them to volunteers who are circulating. Also want to remind folks to put your completed evaluations in the box out in front. Very helpful. Another great way to support the Rocky Mountain MS Center throughout the year, an opportunity is coming right up, which is Colorado Gives Day. So just wanted folks to be aware that Colorado Gives Day is December 6th, so mark your calendar. And you can find out more information at mscenter.org. And now I'd like to welcome Drs. Vollmer, Corboy, and Alvarez to the front for our question and answer period. And we'll gather here shortly, and Dr. Vollmer will lead us in answering the questions that you all have submitted. Thank you so much.
Colleagues here. He's younger and smarter than John and I are.
By far.
So the first couple questions are just related to Dr. Corboy's presentation, just a little clarification. The first one, you mentioned the lesions wrapped around the vein, not the nerve.
Yes, so as it turns out, this is, you guys can hear, right?
Oh, good.
Yeah, so as it turns out, it's been known pathologically for many years, even back to Charcot, who did the first pathological studies in the mid to late 1860s on MS and helped really define what MS is pathologically. It's been known that the lesions are literally wrapped around veins. So there'll be demyelination, damage to the axons, the cables that connect one nerve to another. But that demyelination, a stripping of the myelin wrapping, occurs circumferentially around a vein, suggesting that the white blood cells that are leaking out into the brain are actually leaking out through that blood vessel. And so pathologically, that's been known for many, many years. And so in comparison to, say, what we call microvascular disease, or a very small stroke, also which can be quite asymptomatic, in which we can see in people that have diabetes, high blood pressure, high cholesterol, smoking, all the typical vascular risk factors, but occur in very small blood vessels deep in the brain. They have no relationship whatsoever to a vein, none whatsoever, and they just show that there's an area wherever is downstream from the artery, where there's a blockage in that artery, you'll see just diffuse damage and not specific damage with demyelination. It'll be just diffusely damaging everything in the region. And that's the biggest differential diagnosis for the little white dots on the brain scans, which is what we so-call microvascular disease, or is it related to MS? And this is one technique, and hopefully there'll be other techniques that will be allowing us to show a lesion and its specific anatomical location that will potentially helpfully improve diagnosis at the very earliest stage.
Okay, so we have a number of questions that relate to the genetic factors, environmental factors, and sex factors in terms of risk of MS and risk of disability progression. Dr. Arroyo, you want to talk?
So try that. Hello? So I think when we look at a lot of diseases, we could say, oh, this is a genetic disease because we have the one gene that we can kind of test for it. And I think that makes it a little bit easy. Or sometimes you can look at things like B12 deficiencies and be like, oh, this disease is easy because all we need to do is put more B12 into somebody. MS is unfortunately a little bit complicated because it seems like it's in an intersection of many different things that need to kind of be in the wrong place or at the wrong time and you need to have a combination of all those things. So breaking that question down, it seems like we have over 250 genes now that we know are associated with MS. But the most common gene, this MHC gene, only accounts for 1% of all the genetic for the effect of genes on developing MS. So you need to have not one gene, but it sounds like you probably have to have the wrong combination of probably many, many genes to be susceptible to get MS. And then that probably has to be associated in the wrong setting. So that might be, for example, having really low vitamin D levels as one of the environmental factors. You probably then have to be exposed to something like some virus or something else that maybe causes the trigger and leads to that immune system to kind of flicker off and start attacking the immune system. And then those genes aren't able to control things very well. And so it has to be this intersection of many, many different things that control this. Gender is important because they probably affect the number of genes and the hormones in the body that maybe regulate some of the immune system. We know that, for example, some of the vitamin D, so the way that vitamin D works is it helps turn on certain genes. And some of the areas where it can do that have been found in front of some of the genes that we now know are associated with MS, for example. And so that those levels of vitamin D can help regulate what genes get turned on and turned off. And so those levels of the genes can then lead to a predisposition to MS, for example. And so all of these things are important. When you look at the genetic component, I think I lost my mic, is you need to look, so the chances of developing MS in the general population, just for rough numbers, maybe say 1 in 1,000. If you're a first-degree relative, it's only about 1 in about 100. So it goes up tenfold. So the genes are important. But even if you're an identical twin, the chances of developing MS are only about 2/3 chance. So genes aren't everything. And then what you're exposed to definitely seems to then have to explain for at least part of the chances of getting MS, for example.
Okay. There's several questions that asked about the immunology of MS, questions about if you have antibodies, are they driving the disease versus how does rituximab and other drugs work? So just a brief comment on the immunology. There's actually been a huge increase in understanding of the immunology of MS in the last couple of years. So the first thing is that we now know that most of the drugs that work in MS actually affect an immune cell called a B lymphocyte. So lymphocytes are a key part of your immune system. It's the part that actually responds to vaccines when you get them. And B lymphocytes are the cells that ultimately make the antibodies that protect you from flu or other infections. It turns out that B lymphocytes are a key driver of MS. And we know that because a couple of our therapies, rituximab and ocrelizumab, work simply by killing B lymphocytes that are in the circulation. The second important advance is that we now know there's a direct connection between the spinal fluid surrounding your brain and lymph nodes that exist at the base of your skull. These are called lymphatics. So that means that spinal fluid is draining from your brain into those lymph nodes. And we know from a study in Yale that these B lymphocytes that drive the MS appear to be produced in those lymph nodes at the base of your skull. And so now we have this understanding that there's this production of B lymphocytes that cause inflammation in the brain. They're being produced in these lymph nodes. They then have to move into the circulation and then cross the blood-brain barrier and enter the brain when they then cause inflammation. Once these B lymphocytes enter the brain and start the inflammatory process, eventually something shuts them off. We don't know what it is, but over a period of a couple of months, that inflammatory event is eventually terminated. These drugs appear to be working, particularly ocrelizumab and rituximab, simply because they're catching those B cells in that transition, moving from the lymph node into the blood and across the brain, and that appears to be a really critical step. Tisabri and adalimumab seems to do the same thing. It blocks the ability of B cells to migrate into the brain. And many of the other drugs, including Copaxone, also work by affecting B lymphocytes. So there's this convergence of data now helping us identify a key cell. And we have projects going on here trying to identify further characteristics of these cells so that maybe we can develop additional therapies. Next question is...
Can I add a comment to that?
Yes.
Is this on? Let me try. So one other question that's been asked for many years, many of you have had spinal taps, then you've had so-called oligoclonal bands inside your spinal fluid. And these are antibodies that are made by your normal immune system. Normally, these antibodies are directed against viruses, bacteria, parasites, and other things. And so the question arose over 60 years ago, what are these antibodies doing in your spinal fluid? They're made inside your spinal fluid. They're not seen inside the blood at the same time that you're seeing them inside the spinal fluid. And so there's been a discussion for many, many years, are these antibodies actually pathogenic? Do they actually cause the disease process? And that has remained an open question. There is some data from our labs here, literally about 5 floors up, that suggests that perhaps they do directly participate in the damage that is produced in the lesion of MS. And so the B cells may function at multiple different levels in terms of the way the immune system turns on and off, but may ultimately also play a role in producing some of the damage that occurs directly in the lesion that's MS.
Okay. So there's a couple different questions that are about Tysabri and the other drugs in terms of PML, in terms of what the cause is, what the risks are, and also if you're on one of these drugs that increase the risk of PML and you stop the drug, does the risk go away, and how long does it take? You want to take that?
Yeah, so just to kind of talk a little bit about the abbreviations, because sometimes I think it becomes alphabet soup. So one of the things you'll often hear about is JC. Sometimes you'll hear about JCV. So the JC stands for John Cunningham. He was the person that they isolated this virus from in the first place. V would be virus. And so when they're looking for the test, and this is a common misconception even within a lot of doctors when they're testing for it, is you're not really looking for the virus itself, you're looking for antibodies to that virus. It seems like the more antibodies that you make to the virus, somehow that ties in with an increased risk of developing the infection, which is PML, which stands for something really long, which is why we never pronounce it and we use PML, progressive multifocal leukoencephalopathy. All right, and so, but things that, in addition to that can help, that matter, include how long you're on treatment, and also if you have a history of being exposed in the past to chemo. And so those 3 things are probably important. Tied in with that, the fourth thing that's maybe coming out a little bit is maybe age. And so we've learned a lot about this from the experience with Tysabri. Tysabri, we found out after about a year of the drug being on market that there was a risk of PML. We didn't see this in the clinical trials. And so this is a really bad infection. That risk persists a little bit after being on Tysabri for probably at least 9 months, and some of that has to be associated with how long the drug stays in your system after you wash out, after you stop the medicine. There's also a risk, and so depending within those different factors, your risk can really vary from less than 1 in 100 to as little as 1 in less than 10,000. And so then you start to look at some of the other medications, and there's been 6 cases of PML with Gilenya or fingolimod, and also 4 cases with Tecfidera or dimethylfumarate. So there's definitely been a number of cases with a variety of other medications. There's been some cases associated with rituximab, although not in patients treated with for multiple sclerosis. And some of that has to be associated sometimes with diseases that have a risk themselves of developing that brain infection, or because we use a lot of other fields need to add other medicines that lower the immune system as well. And so there's a risk with a lot of these different medications, but that risk, we can kind of help stratify it depending on some of these different factors. And so those are the things that we look at when we're trying to counsel patients about the risks of PML.
Okay. John, there was one question about what is ATP?
Sorry, another long word, adenosine triphosphate. And so without going into the biochemistry, which I would get lost in the weeds very quickly, it's triphosphate, means there's 3 phosphate groups added on, and as the phosphate is released, that gives off energy. and the cell will use that energy when you go from ATP to ADP, diphosphate. It'll use that energy for any of a host of different functions inside the cell. So if you think of the power plant inside the cell, in virtually all cells, not all cells, but almost all cells, it's the mitochondria, and the mitochondria have this ability to generate ATP so that all the different aspects of the cellular function can continue. Without ATP, the cell will die.
Okay. There's a number of questions on exercise and diet, and I'm actually going to defer them because we have a whole panel that's expert on this, who's coming up shortly to talk about that. There was a question on one of my slides about the title. So it was on that slide where I had all the drugs and I was comparing them, and one of the headings was the risk of AE. I'm sorry, I should have told you AE stands for adverse event. It just means that patients had a problem from the drug. Okay. So a couple questions. One is how can, actually several of them here, comes down to how can we help your group support the change in approach to treatment and management of MS from a societal standpoint?
I think sometimes some of the discussions, for example, I think start off globally and just kind of getting the message out. And I think sometimes it's getting the message out sort of locally. I think probably about half of the patients that I see that have come around, it's because they've talked to some of the patients that have either been to some of these meetings or have come for treatment through us. And so just sometimes even kind of putting the word out, saying like, this to me makes sense. If it makes sense for you, these doctors are not willing to allow for, being okay with more attacks and more lesions in the brain before changing therapies or reevaluating things. I think that's, at the very basics, one of the easiest ways that we can get the word out, to be sort of very vigilant and aggressive about how we treat. I think also just informing about, hey, we don't have just one or two drugs, because that's another common practice that we see in the community is, I feel very comfortable using this one drug to treat MS. That drug may not fit everybody. They may have a lot of success treating one or two people, or a small group of people, but that's not going to work for everybody. And so taking the ability to kind of have and use all of these different medications, don't let them go to waste, kind of a thing.
And if I could add to that, advocacy plays a very large role. The grant that we have that's going to look at discontinuing disease-modifying therapies is from the Patient-Centered Outcomes Research Institute. This is an offshoot of Obamacare, in which the insurers are taxed. It's a pass-through through the federal government to a private nonprofit, and PCORI is a private nonprofit, and they decide what to study, how much money to spend. Dr. Vollmer is submitting in a couple of hours another large grant. If he's not here in a couple of weeks, you'll know why. They ask patient-centered questions, and for our grant, it was a no-brainer that was a logical type of location for our grant to end up, because it's a fundamental question that people have is, when you start any medication for any reason, when do I stop this? And yet that question has literally never been asked. And so advocacy in the context of participating in PCORI, we're going to be going to Washington in a couple of weeks. I'm taking one of my patients with me. We're going to be participating on a panel where we talk about all the issues around the use of medications and how you stop them and how you start them and how you use them over time. But in addition, advocacy locally makes a difference. Every January, the Medicaid Pharmacy and Therapeutics Committee has a meeting about MS medications and other related medications. And every year, whoever wants can come and can advocate for having whatever they think is appropriate to be on the Medicaid formulary. I've been going for about the last 5 years, and every year I argue over and over and over again for a more open formulary, because most insurances, including Medicaid, will have so-called step edits, where you are required to fail drug A, B, or C before they will pay for D, E, and F. Many times the D, E, and F are the drugs that we would prefer to use as a first-line agent, because our view of the world is we do not accept any disability in any patient at any time. And in order to achieve that, it is pretty clear, it is overtly obvious to anyone who looks that there are differences between these medications. And when I get up there and talk, you know, the panel's pretty impressed. When a pharmaceutical company representative gets up there, they're completely unimpressed. When a patient gets up there and talks, they're overwhelmingly impressed at what those patients have to say as to what is important to them, what should be on the formulary, why it should be on the formulary. So get involved. There are a number of ways we've been trying to work at the state legislator level to try and get a more open formulary, to try to get transparency as to why insurance company X will change their formulary in November and will no longer have a drug on their formulary, for example. Get involved with your state legislature, get involved with the Medicaid P&T committees, get involved with groups like PCORI, work for the National MS Society, work for the Rocky Mountain MS Center that are important to try and help push these advocacy organizations, and do all of that. We do much better when the patients are involved, because whoever could be potentially listening knows it's real when they hear it from the patient.
Okay, thank you. A couple of quick questions. One, is there a washout period required before starting ocrelizumab? And the answer is in general, no, not for the interferons, Copaxone, Gilenya, Tecfidera, or Tisabri. The exception would be if you were treated with some of the third-line therapies, which are the alemtuzumab, mitoxantrone, daclizumab. Those therapies are more complicated, but there's very few people that are on those. The question is, will we be switching our rituximab patients to ocrelizumab? Don't have no idea. There's no particular advantages. From a medical standpoint, it has to do with insurance and things that Dr. Corpay's been talking about. So this next question has to do, is two questions together. Do males diagnosed later in life, say 50 years of age, have a different course in terms of progression than patients diagnosed between 20 and 30? And another patient says that he's had no relapses the last 12 years, but he has increasing stumbling and balance issues. You want to take that?
So I think the field of multiple sclerosis is an area that sometimes the words that we use are a little bit, could be improved upon a little bit. Because sometimes we talk about MS progressing, and that's a little bit different from when we talk about sort of progressive phase of MS. And the way I think about it is there's patients that can progress because of relapses or these kind of short-term events that I think of sort of as being bruises in the brain or the spinal cord. And then this progressive phase, which is very slow, gradual, and kind of mimics a little bit, just, you guys have a lot of experience with this, but sometimes I think in helping to explain it to other people, a little bit kind of like Alzheimer's or Parkinson's, in the sense that it's, you know, day to day, week to week, month to month, you don't see much of a difference. But kind of you start going back, man, a year ago I could really do these set of things that I can't do anymore. And that's what we're talking about with the progressive phase of MS. We don't understand that phase very well. We can't tell from a pathology perspective what is different between somebody who looks like they have a relapse and remitting course and those patients that are starting to have progression. We're getting senses that, you know, the patients that have a progressive phase might have more of a brain atrophy or the shrinkage of the brain, that the patients who've had a lot of relapses have more of the white spots and scars that are kind of left behind. But these things are probably more of a spectrum and less of different types of a disease. It's not like you have two diseases, the relapses or the progression. And so I think in the discussion, it's important because it helps us kind of tune in a little bit to sort of how to manage things, how to treat things. What we know from the natural history things is that it's very unlikely to see the progressive phase of MS in a 20-year-old. And yet we routinely will get patients referred to us of this patient we're not treating because they're progressing. And it's because they're having so much inflammation in their brain that they're having one attack on top of another one, and there's no remitting because it's just going downhill. And that going downhill is very fast. They're going downhill, by the week, by the month. That's not that progressive phase. This course of kind of slow, we can kind of get a better sense that it usually tends to start maybe more in the, earliest maybe 40s, maybe 50s, 60s. I think if MS patients live to be 300 years old, that probably the majority without some of these treatments would become progressive patients. I do think that if we can stop the relapses, we could potentially stop some of that progression. And that kind of goes to all the talks that you've been hearing this morning about sort of stopping some of that atrophy, trying to delay sort of and improving that cognitive reserve that we have. And so you can get spectrums and people can always present earlier, younger. MS has been diagnosed in kids that have been less than 1 year old, but that's not common. The typical age for relapses tends to be 20s, 30s, progression may be delayed by 10 or 20 years.
So we're going to wrap up here in a few minutes, so I'm just going to deal with a couple quick things. One is what is considered a significant dose of biotin to improve energy in secondary progressive MS. What was used in the study was 300 milligrams, if I remember correctly, and what you can buy over the counter is usually in the microgram range. So it is possible to have a compounding pharmacy make 300 milligram capsules, but again, all we have is one study. We don't know for sure that the drug really works. That's what the new studies are about. And one other question was, how do you convince a doctor who has a son on Copaxone to move on to one of the newer, more effective therapies? That's a major challenge. I'm not sure I can tell you how to do that.
A simple answer, get another doctor.
I would agree that we're happy to talk with any physicians about why we do what we do. I'm more than happy to do that anytime. And but as John said, you might want to get a second opinion. And then the last question that we can deal with, because this is going all day, is what about complementary lifestyle therapies like massage, acupuncture for spasticity and pain management, and cannabis for MS? And what are the concerns with these pathways, effectiveness, and safety?
So I think, we definitely have to look at drugs, and I think I always kind of end up making a deal with patients of, hey, all right, if we need to be on a disease-modifying therapy, we need to be on a disease-modifying therapy to kind of tackle what those medicines can do. And it's important to understand what some of these medicines can do and can't do. One of the things that our medicines will not do is treat pain. They will not treat spasms. And for that, we need sort of symptom management. And I think that's a huge part. Once the damage is there, it's there. And we need to really work on any sort of way that we can to kind of work on those symptom management approaches. I think that involves using anything you can. If you find that you get relief from drug X, then that's what you try and do. I like to tell the analogy to a lot of my patients that I have the world's best placebo effect to Excedrin for my migraines. I get a migraine, I grab the pill, I put it in my hand, and before it's in my lips, my headache starts to get better. I know it's placebo, I know it's not the drug, I'm not going to stop taking the pill because it's working for me. And so I think that is important to kind of understand with these other therapies. If you find relief from acupuncture, it's not hurting you, I don't see an issue with that. I think the part to kind of look at some of the symptom drugs is sort of the effect on the pocketbook sometimes. Some of these things can get really expensive, and I think that's something that you have to weigh in. If you're not finding relief, then it may not be worth it for you to try and do some of those things. I'll do a special comment on marijuana because I think we do get a lot of patients asking about that. The way I kind of think about marijuana is sometimes we will hear about the anti-inflammatory effects of marijuana. I have not seen a lot of data to help support that. I would not think of marijuana as sort of a disease-modifying therapy. I think you can look at it from a symptom management perspective, and it does. We do find a lot of patients that report some benefits as far as pain, spasms, sleep, appetite, as some of the things that they do get some benefit from that. I would push people not to try and smoke it because we know that it's not the stuff that we think kind of comes with it, kind of like tobacco. I don't have an issue with nicotine, but I do have an issue with all the coal tars and everything else that goes with it. And so if I can, I try to push people away from the smoking forms and maybe more and towards some of the more purified compounds. I think, however, we need a lot more information and data to kind of see, what the right doses might be, what the right compounds within marijuana might be most beneficial, and those kinds of things. And I think there's going to be a lot of information that comes out, maybe depending on the election, sooner or later.
Yeah, the only other comment I would add is that it's difficult to make specific recommendations in large part because there's not a lot of data that helps guide us. And so there may well be one specific diet or two specific diets, for example, or one or other supplement, or one or another approach to a various symptom control. But because the data is so limited, especially with regard to cannabis, it's just very difficult to make any specific recommendations. So what I tell my patients specifically about cannabis is, if you're going to try something, try it, but please be systematic about it. I share the opinion about smoke. I would say, use a gummy bear or some other technique that allows for not smoking. My bias would be to try and use a CBD as a cannabidiol product as opposed to one that is high in THC, tetrahydrocannabinol, which is a psychoactive, one of the psychoactive components of cannabis. But also to write it down, to see what you do. If you try one, try that. If it doesn't work, write it down, try a different one, and also then come back and tell us. And that's the only way we're gonna learn about this in the short run without formal studies, is for our patients to tell us what's working and what's not working for them.
I would add that as well for any drug that we prescribe. So sort of
Absolutely.
we go up on your baclofen, help us help you kind of a sense. Hey, I went up on the drug that it helped. No, all right, let's go back down. Because otherwise you're just kind of accumulating a lot of the side effects and things like this. And then just, partly realize that for as much as we might go through medical school and things like this, there's a lot of these complementary alternative medicine approaches that we may not be familiar with and maybe can't really help guide you too much. And so just the understanding that, we may need to send you out to other people that can kind of help answer some of those questions. You do not want me to do acupuncture on you. It may be fun for me, but if I start smiling and grinning too much, you got the wrong person.
Okay, again, I'd like to thank you all very much for coming out and participating today, and we look forward to the second half of the program. Thank you.
Thank you, Dr. Vollmer, Dr. Corboy, and Dr. Alvarez very much, and thank you for all of the great questions. Really appreciate it. If we didn't get to your question, then I promise to follow up. We have an electronic newsletter that we send out, so we'll be sure to follow up on those questions we didn't have a chance to get to. Now we are going to take our 15-minute break, so the doors are opening behind you. Please do take that break. There's coffee and tea out there. Be sure to visit the seminar exhibitors, and it is a 15-minute break, so we'll reconvene at 11:15 back here. Thank you.
Unless you want to. All right. Well, you know what? I'm washing my hands of this. All the feedback is Dr. Hubert's responsibility.
All right. Thank you for joining us back in the room. We'll get started here. Want to be respectful of everyone's time. Just really appreciate you all being here again. And now I'm very pleased to have Patricia Daly, Dr. Jeffrey Hebert, Shannon Cornell, Tracy Mann, and Tom Stewart here for our panel discussion on living well with MS. So please join me in welcoming our panel.
Good morning. I'm Pat Daly, and I've received very strict instructions about what not to bump or move or knock over. So you've just spent a couple of hours learning about your neurology and your central nervous system and what you need to do to take care of that. But when people have MS, their central nervous system isn't the only thing going on in their lives. There's the rest of your body and the rest of your life. And so this panel is to try and hit some of those issues about what's going on in the rest of your life and how you can pay attention to those things and possibly prevent problems that get kind of neglected when you're busy taking care of your MS. So my panel today, I have 4 experts. Jeff Hebert is a physical therapist and on the faculty at the university and a researcher, and he's been doing physical therapy and research and all kinds of things with exercise with MS patients for a very long time. 18 years, okay. Next to him is Shannon Cornell, who's, this is really kind of very awkward here. Shannon Cornell, who is a nurse practitioner at the clinic, who's been working with MS patients for a couple of years, and before that was working in general adult medicine. Is that right? Cardiology? Yeah, okay. Next to her is Tracy Mann, who's works with the Wellness Center here and is a dietitian. And next to her is Tom Stewart, who has been working in the MS world for a long time, is a physician's assistant and anchors the MCPN MS clinic, but had a career before that as an attorney and has gone back to being attorney. So we're going to try and talk about how to stay out of trouble with your MS. And so my first question goes to Jeff Hebert. So Jeff, we've heard a lot about the importance of staying physically active and the importance for people with MS in having a good, healthy, active lifestyle. But what does that really mean for someone with MS? And particularly, what's the difference between exercise and activity, and how do you think about that? Because people with MS cover a range of abilities and disabilities.
Yeah, that's a really good question because, first of all, I want to thank everybody for sticking around and actually coming out today, spending your Saturday morning, beautiful fall morning with us, because obviously we think this is very important for obviously patients with MS. So if we went back 20 plus years ago, exercise and MS didn't go together. It was you get fatigued, your response to exercise is negative. You know, you might have more fatigue, more muscle failure with exercise. So I think we're in the stage now of what we know about the pathophysiology of MS and how it responds and how the person with MS, because you are people. And so I could pull 1,000 people off the streets and say, yeah, you should probably exercise more. You should be more physically active. But for a person with MS, because as of today, as of tomorrow, we don't have a cure for MS. You are living with the disease, and we have to then structure your lifestyle, help you structure your lifestyle to fight against that disease. Because we are now seeing exercise and physical activity as an actual drug. It should be prescribed as such. And here at the center, you have your disease-modifying therapies, but we also are starting to see that exercise and physical activity and a healthy lifestyle doesn't come second, third, or fourth. Many times it starts to become parallel with the need at the front line. Dr. Vollmer and I wrote a paper amongst many different national recognized exercise experts in MS that said exercise should be a prescriptive therapy. This is coming from a world-renowned scientist and clinician, and myself as an expert in exercise and MS, saying that exercise is very important, should be one of the first things we talk about. So exercise and physical activity. I think you need to work with individuals that know the disease and work with your lifestyle currently and how you can design your day in and day out life to purpose things that you might not think of as exercise. Walking to the mailbox if it's a long distance away, coming back, or at work, if you're walking up and down stairs, you need to think about that being purposeful exercise. And that accumulation over time as a regular exercise program, we don't have to be saying you have to do 3 sets of 10 with X amount of weight for X amount of time. If we work together and say, throughout your entire day, what does this look like? Are you actually exercising at a good amount and you don't even know it? And keep that up, and how can you purpose that? So exercise, physical activity go together, but it does not have to be an actual prescribed exercise program of this amount of strengthening, this amount of endurance training, but you think about it as your daily routine could be purposed for exercise.
So a follow-up question to that. If someone has questions about this, is it useful to consult with a physical therapist just around these issues of what would that look like and how can I best accomplish it?
Yeah, I'm going to lead off with absolutely, but I'm going to also chase that with it has to be with a physical therapist that at least works with persons with neurological conditions and, more importantly, working with persons with MS and know MS very well. Just like any profession, not all physical therapists are made equally and trained or have the experience. This is very specific. I really caution you to be getting a referral that goes to a physical therapist. You need to make sure that that physical therapist that you're going to knows this. And I'm hoping to push the change in paradigm of rehab in MS, because rehabilitation sounds as if we're trying to create some type of solution after a bad thing happens, after an attack happens. That's when you think about rehab. That's when you think about physical therapy. But a person like myself, yes, I'm a physical therapist, expert in rehab and MS, but it's also how to design a healthy lifestyle for you. And that's different. That's actually being ahead of the disease curve and the disability curve and not waiting for something bad to happen. And it's never too late to inject that into your life.
If
So-
I'm,
Yes.
is this on? I think this is on. And if I may, some of these, we have a spectrum of patients regarding their disability or their activity level. And just going to see Dr. Heber or somebody else, physical therapy for a one-time consult may be enough to get a program tailored to you and your level. So I know that there sometimes is a stigma when we recommend physical therapy, but again, as Dr. Hebert was saying regarding lifestyle changes, getting ahead of the curve, sometimes just a one-time evaluation may be enough to affect your daily lifestyle.
I've heard people say over the years, but I'm not bad enough to see a PT, or my neurologist says I'm not bad enough to see a PT, and I say, boy, the time to see a PT is like the time to start saving money when you have some, not when you're broke,
Right.
right?
And I see it as all my patients that come in, yeah, I might see them one time consult, like Shannon says, but now you're connected.
Yeah.
Now you're connected with your primary rehab specialist that knows MS inside and out. That's really important because it's not just the one time. It could be like, well, let's see you when you 6 months later, 12 months later, 24 months later, because you're continuing to live with MS. We don't have the cure, so even continued consults would be helpful as well. That's really important.
What would you say to people that live out of the area, out of Denver, who don't have those accessible resources as far as physical therapists that may have that background?
Right. It kind of goes to the one-time consult. So you still want to try to, we can try to help individuals find specialists in MS and rehab in your area. And then I have for years have consulted remotely with those specialists as well. At the very least, I see patients from Alaska to Nebraska to, the rural areas of Colorado, again, for that one-time consult. But when you are in the area, maybe seeing our frontline providers, then we schedule you for another session with myself. I'm not promoting, hey, come and see me. Maybe I am, but it doesn't have to be that way. I'm just saying, making sure that you're hooking yourself up with an expert in that. And yes, you might not have that in your area, but we're here to help at least jumpstart that for you and then guide you through that process.
So as long as you're chatting, Shannon, my next question is then to you. How people see a neurologist for MS management maybe twice a year. So how can people use that time and be prepared for that appointment most effectively? What do you want, in the ideal world, what would you like people to do to prepare for their appointment with you?
This is a very good question, and yes, it is. Keep in mind to frame in an ideal world as far as how many patients everyone is seeing in the clinic and at what time, and schedules and parking and those types of things. But I would say, first and foremost, try to get there at least 15 minutes beforehand so we have enough time to sit you down so we can maximize that 30, 40 minutes that we see each other. Because not only do we have to check in, park, check in, get into the clinic, check in, and then have the MA do the vital signs and ask a few questions. That's when the provider sits down. That's when the clinic appointment starts. I want to use as much time as I can to be with my patient. So getting there early, if you can, I know obviously things happen, having your medications ready, either bring the bottles, have them written down. I always like to review them with my patients so we both know as a provider, medications are not benign. Side effects can happen, interactions can happen. We need to talk through that with each other. And make sure I know, as your clinician, you're taking the right medication, the right dosage, and that you have knowledge about what you're putting into your body. Come in with a list of questions that you have so we can cover everything. I know, a lot of things are going on when we're talking and we get sidetracked, but I want to make sure that I answer all of your questions that you want to get through. Because again, I may only see you twice a year. I may see you more, or you may be out of town. So again, in order to get through everything, just have those questions prepared. Aside from medications, questions, please bring family members. That's always helpful. They can always add to the value of the time spent together. And I know, depending on family members, they like to interject and say, well, you forgot this. And it's kind of, oh yeah, I did forget that. This is going on. There's things that happen in the clinic as far as clinic flow. So again, I want to see you for as much time as that I can.
So what do people need to keep track of between appointments? Some people keep a really detailed diary of all of the things that happen to
Yes.
them, and some people don't remember or don't pay much attention to what happened last week. So what is helpful for you to know?
I would say, especially to kind of go back to the first question, bringing MRIs and reports are another huge delay for us. It is part of the diagnosis, prognosis, management of MS. So if we don't have your MRI on file, please bring the CD, ask the radiology department wherever your MRIs were done, get them to burn it on the CD, bring the CD. We can upload them into our computer and review your MRIs together. Or at the very least, get the reports. As far as a diary of what should be recorded, anything that's important to you and affects your daily life, I would say symptoms. Symptoms is what affect our patients' daily lives and their quality of life. Anything that's new or concerning to you or worsening, especially over longer than 24 hours, write that down and have a date and time. I want to know, is it continuous? Is it intermittent? Is it transient? How long? When did it start? Were there extenuating factors at that time? Stressors, changes in routine, infections? These are the things that we continually ask. And if we have a little bit of a a record or a timeline that'll help move the interview together more quickly. And it'll actually help you gauge the patterns of your symptoms. And we can come to maybe a better conclusion and management from there.
Okay, thank you.
Welcome.
So I think I'm going to send the next question to Tom and bounce over you, Tracy, because it follows up on what Shannon was saying. So, Tom, you run a disability assessment clinic, and when people have MS, when people have been diagnosed with MS, it's not a guarantee of disability, but I think it does put people at increased risk for developing a disability, although treatments are getting better, and I think that picture is changing. But in conversation with you, I was surprised when you told me that people who are 20 years old today, a cohort of people who are 20 years old today, probably 1/5 of those people will be disabled by some condition before retirement age. So this question of how to prepare yourself in the event of a disability is one that's relevant to people with MS, but relevant to all of us. So what do people need to know, and what kind of tracking do you need to have to substantiate medical problems?
Okay, so I actually looked it up last night, and for 20-year-olds who don't have disease, there's actually a 25% chance of being disabled before age 65, retirement age. And so the implication for that is that I think it's just good hygiene for everybody to understand what would happen in the event that they become disabled. And when I use the word disabled, I'm using it in a different way than others sometimes are using it here. For my purposes, disability means losing the ability to work. So many people, whether or not they have MS, are at risk for losing the ability to work. And of course, with people with MS or any other chronic disease are at further increased risk. So it makes sense to understand, the implication is to understand what would happen, what is your plan if you lost the ability to work, right? Bearing in mind that it's not only obviously a loss of income, but it's also a loss of medical insurance and possibly access to medical care. So maybe I'll just spend a couple of minutes going through the major answers to that question, and it might help for people to kind of reflect where you are in this. How would you be protected in that event? So it starts, I think, the way I think about it is, do you work for a private employer or do you work for a public employer? And so if you work for a private employer, the most important safety net by far is Social Security disability insurance. And so if you work in the private sector and pay taxes, as everybody does, and you've worked long enough and recently enough, that is to say over the last 5 years, then you're going to be insured for purposes of Social Security. And if you can prove to Social Security's satisfaction that you're disabled, meaning you can no longer do your current job and you cannot adjust to other work, then you'll be entitled to an income stream, a modest income stream, but enough to keep many people out of poverty for life. It's inflation adjusted. And in addition, comes with an award of Medicare. So critical benefit, most people don't even know about it. It's just taxes. Well, I sometimes joke, if you look at it, that's the only part of your taxes where you actually get something. So look at the FICA taxes. I mean, that's your Social Security disability insurance. So it's not a perfect system. It's sometimes hard to prove disability. It takes 6 months before you're entitled to your first check from when you stop working. And it takes 30 months to get Medicare. So it's a very rough transition for some people. But again, it's the primary safety net for people with disabilities in this country. And then there's another protection for people generally who work for larger employers like the Martin Mariettas of the world. So in addition to Social Security disability benefits, a lot of people get private disability benefits. And so private disability benefits would be taken out of the paycheck in addition to Social Security. And what that would do would protect you in the event that you became unable to do your current job, which is different from the standard for Social Security. So imagine again at Martin Marietta, a rocket scientist who develops mild cognitive problems but is otherwise very able to has a lot of residual function. In that instance, in theory, the person who is a rocket scientist should be able to collect benefits from the disability company. And these are often very generous benefits, especially for high earners. Some people who have that kind of policy, they will have that policy turn after 24 months into an any occupation policy, meaning it's the same standard as for Social Security. So it's important if you have a private disability insurance company to understand whether it's an own occupation policy or an any occupation policy. And while I'm at it, if you have the opportunity to buy disability insurance and you have and you work and you have MS, you should. If you have an opportunity to buy additional insurance, you should.
Can I interrupt for a second?
Sure.
If someone has MS and then they go to work for a big corporation and they have the opportunity to get disability insurance, are they prevented because they have a pre-existing condition?
Great question. So they are, if they start to work for Martin Marietta and they get an excellent disability package on day one, and then on day two they say, oh, I can't work, I'd like my disability benefits, that is a pre-existing condition. And you would not get benefits. But after 12 months, it's no longer a pre-existing condition.
Okay, thank you.
So there's a little bit more to it than that. Obviously, you're in that situation. You have to count very carefully time off from work, but as a general rule. And then just two other quick points. I realize I've talked quite a bit here. So if you work for a public employer, like teachers do, then you don't pay into Social Security, you pay into an alternative system, PARA. And that's also an excellent disability program. It saves a lot of people. One thing I would point out about that, it's less favorable than Social Security in one respect, and that is that you have 90 days to apply for disability through that program. So if you stop working, let's say as a teacher, and you want to go home, you want to stay home and raise kids for 5 years and go back, and then disability and inability to work intervenes and you can't go back, you're likely not to be eligible for benefits. And then finally, in theory, people could buy private disability benefits in the marketplace, but for people with a chronic disease, that's not practical at all. As I understand it, there's a way to do it by buying life insurance. Sometimes they have riders for disability. But it's like Pat said, the time to save was when you had money, I guess, and, to have bought the policy prior to a diagnosis. I suppose if you're at high risk for developing MS, it might be smart, like if you have a twin with MS. But as a practical matter, that's not going to be a useful resource. So what all of these have in common is they're protections for people who are working. So for people who aren't working, I think they're the ones who have to kind of think about this hardest and what would happen to them if their plan is to go back to work and then they're no longer able.
Okay, thank you. So Tracy, you're a dietitian. We get about 1 million questions a day about diet and MS. And I know for some medical conditions, there are specific diets that are recommended for people to follow that make a big difference in the condition. Is there a diet for MS?
That is a good, can you hear me? Okay, no? Can you hear me now? I don't like microphones, so is that better? Okay, that is a good question, Pat, and I guess you could look at it good news or bad news. The good news is even if you have MS, you're just like the rest of us as far as diet and nutrition. Fortunately, there is not a specific MS diet at this point. There is research being done with different modifications that you can make, but nothing that I could say, this is where you should go, this is what you should do. General guidelines would be just trying to eat an overall healthful diet. And if you are at risk for any other chronic diseases, whether it's hereditary or lifestyle related like heart disease or cancer or anything, then we can guide you toward eating plans that may help prevent those types of things. But if you're looking for an already tried and true diet that you just want some guidance, you don't like to have to decide for yourself, the Mediterranean diet is kind of overall the most researched diet. It's been more researched for heart disease than MS, but I like the basic guidelines. It's a plant-based diet, reduced saturated fat, lots of fruit and vegetables. So those things are not going to hurt you.
So, what about other diets? We hear a lot about a paleo diet or a gluten-free diet, or there are a whole lot of diets out there. And I know they haven't been well researched, so we don't have a lot of data about whether they help or whether they don't, but people still do them, and some people find them helpful. But what are some general guidelines if someone decides to follow a diet like that? How long do they have to do it? What do they need to be thoughtful about? What can they reasonably expect in terms of how it's going to be helpful or not? And how long do you need to do it? And how do you know?
Those are all good questions. Definitely, if you Google MS and diet or multiple sclerosis and diet, there's going to be a million things that come up that say, this is the one you should do. And the way I work in my practice, and all dietitians are different. It's just like finding a physician or finding a physical therapist. We all have different knowledge and different methods of practicing. I tend to say if there's something you want to try, you can definitely try it. You want to make sure that you're meeting all of your nutrient needs. So if you want to try a gluten-free diet, just make sure you're getting some of those vitamins that you would normally get from your grains. And that might be a good time to maybe meet with a dietitian, just so they can go over it. If you came to me and said you were doing that, I would definitely help you through that. I wouldn't say, oh, there's no research behind that. Don't be doing that. I'd try to help you work around that if that's something that you've looked into and want to try. I think the other thing is, if you are wanting to try something that looks somewhat restrictive, make sure that it will work with your daily life. You may see something that says this is the one, it's going to make you feel better, and you look at the plan and the foods that you have to restrict, or maybe some really expensive foods that you're supposed to include on a daily basis. If it doesn't look like it's going to fit with your lifestyle, that might not be the plan for you. As far as how long to try it, I think you should, if you're really going to be serious about making a huge diet change and you're looking for maybe some specific symptom relief, you'd probably give it at least 30 days, if not longer, and kind of track your symptoms and see if you're seeing any benefits to that.
Thank you. So I have a question for the panel at large. And this is about how people talk to their healthcare providers or the people that they interact with. So I don't know in the audience how many of you have ever lied to your dentist about how often you floss, or how many times you have lied to your physical therapist about how many times you did your exercise program, or how many times you took your medication. So this is a question for Jeff. Jeff, you know when we lie, don't you?
Am I on?
So I think the reason that we sometimes don't tell you the truth is because there's so much going on in our lives and we don't have time to do all of these things. So do you know when we lie? And how to get around that? Okay.
Excuse my language, but hell yes, I know when you're lying. But
I thought you
I do
did.
say, honesty that's the only way we can help as practitioners. And without that honesty, I mean, there's absolutely no judgment. That's one thing you have to realize, is that we are definitely here to help you. Every time you're with us, you have our full attention. You are our N of one that we are working with at that time. And so we're not here to, again, judge whether you're doing it or not. We're here to help you to stay consistent. And this goes to, like, let's say we are asking you to be a little bit more physically active. That's maybe a change that you've never been really physically active, or you have, but we have to design it differently. There's steps of change that happen whenever we're adapting or trying to adapt or adopt healthy lifestyles or getting rid of bad habits. There's always a stage of changes that we go through. We will fall down those steps of change, but we have to then get back up. It's just human nature to fall off the wagon, if you say, but that's fine as long as you don't drop it forever. You're living with MS, so it's always going to maybe be a moving target, and we have to then move with that target with you and find a way to do that. But without that honesty, and that openness, we can't help as much.
I would say that as well. From the provider point of view, again, there is no judgment. I appreciate how you say that. And we are human and things happen, life happens. And if you are as honest as you can be with us, we can get to the cause of, well, what else? What happened in this situation? What's deeper that we don't know that we can bring to the surface, and we can work on that to help make you more successful. We want to be partners in your care. We'll tailor your care. We'll be there for you. And education is the best way to start to empower you and your knowledge. But we can't get you there if you're not telling us what else is going on, and we want to know. And we're going to be there, and we're going to every step of the way.
So what I hear people say when I say, oh, did you talk to your neurologist about X, whatever that was? And the response I often get is, well, I didn't want to whine. I didn't want to be a bad patient. But there's a downside to that. If people don't tell you actually what's going on and it doesn't get in their medical record, which I think is a question for Tom. But the other thing is, I think a lot of times people don't know what's an MS problem and what's not. So sometimes they don't talk about something because they don't think it's relevant when maybe it is. Is that right?
Yes, I would agree, especially when somebody is newly diagnosed and they don't know themselves, is this an ache or pain from twisting my ankle, or is it related to MS because I have some weakness there? And that is why actually within the first year, if we start seeing you, we see you so often so we can have that conversation to figure out what symptoms may be related to MS or not. Sometimes we don't know, but continued conversation and we'll get through that to tease through it. Anything that's on your mind that you think is concerning to you, or maybe somebody in your family has noticed something, please bring it up and don't be afraid to do that. Because it can then open up another door and we may have to investigate that further. So anything that's affecting your quality of life, your daily life, please bring it up to us. We want to know.
So, and this is a question for Tom. There is a real problem when people don't report certain things, yes? There can be.
So I'll try to come back. Actually, I had a comment related to what Shannon was saying too. But certainly, if you do have a disability claim, what's not in your medical record will be doubted. So if you have fatigue that's beginning to interfere with work, or you come home and you've got absolutely no energy, I mean, these are kind of early, mid signs of problems at work, and they should be in your medical record, and it actually might undermine your disability claim if everything's fine until the eve of your application, then all of a sudden you have multiple symptoms not previously recorded. So it's to create a longitudinal history is very important. And then I also wanted to chime in a little bit as one example that of what Shannon was saying, and maybe a little more generally, is sort of a tricky symptom that maybe sort of people don't recognize right away. Insidious would be irritability, or symptoms of depression in general. Other symptoms, fatigue, of course, that takes a lot of close analysis to see what's causing that. I think depression I think it's the worst MS symptom because, unlike, for example, weakness in a leg, for example, which will not harm a relationship. I think that depression, which is extremely common in MS, really damages relationships, which I think makes it one of the most concerning symptoms. And so that's just an example of things that may not be obvious as an MS symptom that you should be talking about.
Thank you for making a plug for mental health, because actually, and people don't know this, but when you look at what MS symptoms have the biggest impact on quality of life, surprisingly, they are not physical symptoms. The symptom that has the biggest impact on quality of life is mood and depression. And it can be a symptom of the disease itself, and with living with the disease, it's a complicated thing, but it's also a very treatable thing. And so I am making, and I think you would all agree with this, I'm really making a big plug for people to be really pay attention to that and to talk to their healthcare provider about that. So we have just a few more minutes on this panel, and I would throw out to all of my panelists, if there's one thing that people can do, what would it be? What would you want? What is the one thing, if you had a magic wand and you could guarantee that people would do this one thing that you think would make a difference in terms of the discipline that you work in, what would it be?
You can start shooting.
I think with any chronic disease or illness is first recognizing that something is going on with yourself, seeking out the best care that you can, and getting a relationship with that group of providers so we can create the best plan and management for you. And sometimes admitting that there may be something that's off is the hardest part, but again, that there's support out there for you, and there's good, the doctors are up here as far as talking about the medical management, but there's other resources as far as Pat was saying, mental health. And putting yourself and your health first and priority is extremely important. And we don't know how to help you unless you get to us as far as your clinicians, and then we can work through it together.
Thank you.
And a lot of times what I see in some seminars that only look at, here's the disease, here's the drugs that we have for it, we don't have a cure, but then end it with that and not have a panel like this that says, here's some other things that are important and other things you can do. And that can be very empowering for you as the patient, that you're not waiting around passively for the cure, because it's probably not going to be in our lifetime, unfortunately. However, there's things you can do, and you can grab a hold of it and take it by the reins, and don't let it have it take you over. And a plug again for physical activity. I'm not saying that's the cure-all for everything, but it is the one thing that you can think of as saying, I'm going to do something that I know has some backing, has a lot of backing to be very beneficial. One was a discussion this morning that is very important, brain health. Preserving, not just preserving, but can it be actually improved? And there's evidence that started in animal research that now is in human research, that started with individuals that are healthy. And then we have evidence in MS specifically that there's a correlation, a direct correlation in that with increased physical activity. I'm not saying, run until you fall over. It's general physical activity. More physical activity can increase brain size. So there was a talk about size of brain atrophy with disease and aging. But again, anybody out there can benefit from more physical activity, and increase certain areas of the brain could actually be increased and possibly increase function too. So again, brain health and physical activity and managing your disease with the drug therapies is essential.
So I just want to stress, so physical activity regardless of your level of functioning, whether you run 3 miles a day or whether you're in a chair, is that correct?
Completely. The spectrum of disability with MS, this goes for individuals that are wheelchair bound to those that are still running marathons. And I see the gamut. Just this week, I saw a person that was an professional mountain biker, continues to do it, and now we're designing things that is going to work for him for his lifelong exercise program. And I see patients that are wheelchair bound that think, well, I'm not walking, so what's the benefit of this? Transfers, bed mobility, better overall health, that looking at possible causes of depression and MS, it might not be that leg weakness, but it could be other things that are leading to that mental health illness that we could target with such things. So I'll get people that are wheelchair bound and getting their arms to maybe help out. If it's only one arm, we'll maybe do one arm cycling to get some physical activity. So we are looking at brain protection and possible improvement in brain health with exercise, regardless of disability level.
Thank you. Tracy.
Can you hear me? Okay. I think with regards to nutrition, because there are so many different ways you can go, I think the first thing is to just be self-aware. Sometimes we go a whole day and don't even realize what we've put in our mouths. So looking at what you're doing, having a little bit of some sort of record can help you be aware of what you are putting in your mouth. And when you are ready to make some nutrition changes, you have a place to start. Or if you decide to see a dietitian or take it into your other clinicians, they have something to look at to help guide you into making small changes.
Thank you. And Tom, you get the last word.
Okay, so this is, I'm going to take advantage of the opportunity and give 3, not 1 answer, because the first answer I've already talked about. So only speaking in terms of what the one thing is that you can do to improve your situation should you find yourself applying for disability. Number 1 would be to be in close communication with your clinicians. So when you have, everything's not just fine, if you're having fatigue, et cetera, if you're having trouble at work specifically, if you're having negative reviews at work, please have these conversations early. The second thing I would say, if you do work for a private disability, if you work for a private company, you should buy as much private disability as they will let you. And then finally, if you are finding it difficult to continue working, you should get expert help as soon as possible. There are a lot of pitfalls as you go through the process. Thank you.
Okay. So thank you very much to my panel, Tom, Tracy, Shannon, and Jeff.
Excellent panel. Thank you all so much. And I want to thank all of you again so much for being here today, taking this time to share together and learn together. And hopefully you leave here feeling very empowered with the information that you are equipped with now. And as always, this is an ongoing dialogue, and we really feel this is such an important part of our community. And as always, if anything comes up, if any questions arise, feel free to reach out to us, our website, mscenter.org. Be in touch with us on our Facebook page, and let's keep this dialogue going. And thank you again. Enjoy the rest of your weekend.